The Joint Committee on Administrative Rules will come to order. If you would like to testify on a rule set on the agenda today, please fill out a testimony card and turn it in to a sergeant or here up at the desk. Will the clerk please take the roll for today's attendance?
Chair Wozniak.
Here.
Representatives Johnson.
Here.
Orts.
Here.
Farhat.
Here.
Carter. Senators Woino. Bayer. McMorrow. Tice.
Here.
Runstead. Mr. Chair, you have 5 members present. You do not have the quorum.
Thank you. Rep. Orts moves to adopt the minutes of this. Oh, we can't do that. That's right. As a reminder to the committee members, any action by the JCAR committee shall be by concurring majorities of the members from each house. That means that 3 representatives and 3 senators must vote in the affirmative on any motion for that motion to prevail. Today, we'll be hearing testimony on JCAR Rule sets 25-51 through 25-58. These are the adult foster care home rule changes. We'll begin with Paige Foltz and Jay Kalewitz from the Department of Licensing and Regulatory Affairs. Come on up. Glad to have you here. All right, just begin, take all the time you need. We don't have really anybody else that wants to testify.
Thank you. This topic is so exciting, so we'll jump right in. Chairman Wozniak and members of the Joint Committee on Administrative Rules, thank you so much for having us today. My name is Paige Foltz. I'm the Director of the Office of Policy of Legislative Affairs at LARA. We're here today to talk about rule sets that are housed in the Bureau of Community and Health Systems. Since that's a mouthful, we call it BCHS for short. BCHS performs regulatory duties as required by both state and federal laws. Their programs are designed to protect health, safety, and welfare of individuals receiving care and services through various licensed, permitted, and certified facilities, agencies, programs, and individuals. The Bureau oversees a whole host of items: adult foster care, which we're here to talk about today, adult camps, freestanding surgical outpatient facilities, homes for the aged, hospice agencies and residences, hospitals, nursing homes, and substance use disorder programs. They also oversee nurse aides, medication aides, and both those trainers and their training programs, and last but not least, qualified interpreters. Their regulatory oversight includes issuances of the licenses, certifications, and permits, as well as routine inspections, complaint investigations, and enforcement activities. To dive deeper into the 7 codes in front of you today, on the agenda, I have Jay Kalewitz, the division director, of adult foster care licensing for BCHS, and I'm going to hand it over to Jay.
Thank you. As Paige mentioned, my name is Jay Kalewitz. I have had the privilege to serve as division director for the past 10 years, overseeing adult foster care licensing. Before I get into this rule set, I just want to give you a little bit more information on what an AFC is. AFC is short for adult foster care. We currently have 3,900 adult foster cares across the state of Michigan, with a capacity to serve a little over 3,100 individuals. We have approximately 55 AFC licensing consultants whose primary duties are to process applications, issue new licenses, conduct renewal inspections on an every other year basis, and they also complete about 2,400 complaints annually. Our licensing consultants are primarily master's prepared social workers, although we have a few that are master's prepared masters in criminal justice. AFC serves adults that are aged, mentally ill, developmentally disabled, or physically disabled, and require supervision on an ongoing basis. You will sometimes hear AFCs referred to group homes or assisted living facilities. Assisted living facilities is not defined in the state of Michigan. That's more of a marketing term. So if you hear that, some are licensed as adult foster care facilities. There are several types of AFC homes. We have a family home, which has a capacity of 3 to 6. and the licensee or owner must live in that home. We currently have 479 adult foster care family homes, and with a capacity of 1,484. We have small group homes, and that is defined as has a capacity of 3 to 12 individuals. We break up that small group homes for zoning and fire safety. So we have what we call small group homes 3 to 6 capacity, as well as small group homes with a capacity of 7 to 12. And I'll explain the fire safety and zoning a little bit later. So the small group homes 3 to 6, there's approximately 2,400 of those across the state, with a capacity of about 1,300 or 13,700, excuse me. And then our small group homes 7 to 12, there's approximately 430 of those, with a capacity of 4,800. And then large group homes are licensed with a capacity of 13 to 20. We currently have about 566 of those, with a capacity of 10,800. And then there are something called congregate homes. Those are licensed for 21 or more. Those have been phased out. You can't get a new congregate home license anymore, as the state moved away from institutions, but there are currently 4 left, with a capacity of overall capacity of about 120. AFC's licensed for 6 beds or less make up a majority of the homes that we license, approximately 75% of them. These homes that are licensed for 6 beds or less are allowed to exist in existing neighborhoods without any special use permit or zoning approvals above and beyond what a single family residence would require. Chances are you may have one in your neighborhood and not even know it. About half of our licensed AFCs serve residents that are community mental health or CMH clients. These individuals can range from fairly high functioning, such as just needing prompts to take medications or assistance with showers, and are able to access the community unsupervised without staff, to some that have some pretty serious behaviors such as self-harm, swallowing inedible objects, eloping, physical and property destruction, physical and sexual violence. Some of these residents with the serious behaviors have spent significant time in psychiatric hospitals, often required enhanced staffing, such as line of sight at all times, or one-to-one arm's length staffing, and in some rare instances, 2 staff assigned to 1 individual. Direct care staff at ASC must be trained and competent in completing their work tasks, but direct care staff are not required to have an advanced degree or even a high school diploma. Since continuous nursing care is prohibited in AFCs, there's not a requirement for a nurse or any other medical staff to be on site at the AFC. It's also important to know that most direct care staff are paid about around minimum wage, or maybe slightly higher than your local McDonald's is usually how the AFCs set their rates for paying direct care staff. I mention this all to show that AFCs are complex. They serve a variety of adults with varying complexities and physical and mental needs. So working on this AFC rule set for all types and all populations has been a process, to say the least. That's why we're so excited to share with you the new licensing adult foster care facilities rule set that we've been working on for a little over 2 years. The rule set will replace 6 existing rule sets. Congregate rule set. So basically each type had its own rule set. So congregate, family, large group, small group. And then there's a rule set for certification of specialized programs. That's basically an extra endorsement on your license so that the CMH community mental health can contract with you for the clients that they serve. And then adult foster care fire safety rules for homes 6 or less. So homes 6 or less, our licensing consultants inspect because it's basically like a residential home. Homes licensed for 7 or more, the Bureau of Fire and Services inspects, because there's some more complex fire safety requirements in those homes. So the goal of this new rule set was to clarify rule language, provide consistency across all provider types, AFC provider types, modernize the rules to fit current standards. This has been the first significant change to our current 6 AFC rule sets since, for Congregate since the 1970s, family homes and the fire safety rule since the 1980s, and the group homes since the 1990s. A little over 2 years ago, we began drafting this new rule set with some of the members of our Adult Foster Care Advisory Council. The AFC Facility Licensing Act creates the Adult Foster Care Licensing Council. It has 11 members appointed by the LARA director and consists of AFC providers, AFC residents or resident representatives, state and local agencies, private or public organizations. The council's charge is to review and provide feedback on licensing rules. Those members that volunteered to help draft that initial draft, I don't think really fully knew what they were getting into. So I want to recognize them. So Deb Mock from Hope Network Behavioral Health was a provider representative. Jessica Cross from Pine Rest Christian Mental Health Services, also another provider representative. And Jennifer Warnos, Guardian Finance and Advocacy Service, was a resident representative. Along with Mickey Streeter and Dawn Tim from our division, they all spent significant time drafting that initial draft and were instrumental in getting this new rule set started. We then brought the initial draft to the entire AFC Council for feedback multiple times and several revisions. I want to recognize the following AFC Council members for their efforts, for providing feedback, suggestions, word changes for clarification, and support of that final version. Kathy Lentz, who's our chair, she's with Integrated Services of Kalamazoo, so that's the CMH in Kalamazoo. Marie Ego from the ARC of Michigan is a resident representative. Jenny Post from Healthcare Association of Michigan. Dan Russell, Genesee County CMH. Belinda Hawks from Michigan Department of Health and Human Services. Jamie Saturino from Quality Living Systems is an AFC provider. Nadine Carlson, Care Provider Solutions, and Lauren Patent, who was a former member and provider for Angels Place. I also want to recognize the AFC Provider Associations, Michigan Healthcare Association of Michigan, Michigan Assisted Living Association, and Leading Age of Michigan for their comments and feedback, once again over several revisions, which helped create this final version, which is in front of you today. We also held a Zoom town hall meeting on October 2nd of 2024 to discuss this rule set. We had 500 people attend that meeting and it received approximately 90 questions and comments. We accepted written comments basically for 2 weeks up to October 16th of 2024. So that, once again, we made some revisions based on some of the comments we received back from that virtual town hall. Public hearing was held on July 8th. We only had 3 people attend, and nobody spoke during that hearing, which I'd like to think is because we had so much input from the community, leading up to that public hearing. We also left that public comment period open from May 9 of 25 to July 8th of 25 for written comments or suggestions, and we did not receive any comments. So no modifications were made after that public hearing. This rule set, again, takes 6 rule sets and combines them into one single rule set. The rule set reduces the number of rules from 206 to 73, and the amount of pages of rules from 120 pages down to, I got a typo in my thing here, I believe it's 37. So that rule set makes it simpler for AFC providers, especially those AFC providers that have multiple types of AFCs, as they now have a single rule set to go to, and they don't have to figure out, oh, does this rule set apply to me, or is it this one? The new licensing AFC rule set was primarily based off their existing group homes. There were several rules that were modified for clarity, and then there was also some significant changes from the existing group home rules. And I'm going to go over a few of the more significant changes. So first, we eliminated the rule requiring routine tuberculosis testing, or TB testing, in AFCs as for direct care staff at AFCs, as the CDC guidance only requires TB testing monitoring at healthcare facilities, which an AFC is not. It sets uniform standard for record retention for licensing purposes anyway at 2 years, with the exception for staff schedules and menus, which is 90 days. Increases the amount of resident funds the licensee can, if they so choose, to hold for the resident from $200 to $400, just because of inflation since the 90s. And then also the amount that if they do accept resident funds, the amount that the licensee has to have on hand to give the resident immediately, from $20 to $40. Again, $20 doesn't hardly buy you and a friend a meal at McDonald's anymore. So. Also changed what was considered a resident valuable from $25 to $100. So licensees have to document when a resident comes in everything that's considered a resident valuable. And once again, $25 is pretty much everything that they bring in nowadays. Changed the notification to the Department of Property Damage from a dollar amount, which was different across our rule sets, to instances where residents are displaced or services are disrupted. This is primarily because when there is property damage, the facility might not necessarily know what that dollar amount is until they have a contractor come out and give them a bid, and it would cause delays. So that's why we made that change. Also, our Act allows for issuance of special licenses. So we created a rule to issue a special license up to a year in instances where there is a fire or another national or natural disaster. Residents of a home could move together to another home. And so that spells out that process. Also, staffing is been a persistent problem in AFCs for getting direct care staff. So we're, based on some of the provider input, allowing minors, now 16 and 17-year-olds, to be considered part of the direct care staff, as assuming that they are trained in the duties that they are doing, with some exceptions that they have to work with an adult staff, and they also have some duties such as that they can't do, such as medication administration and transportation of the residents. We are right now the licensee, the resident, and the resident representative, and any have to review the resident's care agreement on an annual basis, and then sign it. We change that requirement if there isn't any changes. Not everybody has to come in and sign it. The licensee can just document that a conference was made and no changes were made. So people don't have to come in and physically sign that agreement. New rule also allows use of non-department form for resident funds and valuables, if their version basically includes all the same information. So we have a old paper form where they had to keep a ledger essentially for every funds that come in and are paid out. Obviously, there's been quite a bit of advancement in Quicken and Excel and many other options, so that allows that to be used. Updates of nutritional guidelines. So our old guidelines were for 1985, so we brought that up to date. Establishes clear standards for facility cooling requirements. So AFCs are not required to be air conditioned necessarily, but if they don't have air conditioning, they have to have ways for residents to be cooled, be that fans, bringing them to a cooling center if it gets hot in the house, and so that explains some of the things that they can do to keep residents cool. And expands, currently our rules only require list physicians. We expanded that to any healthcare professional that is practicing or doing duties under their scope of practice, because we have PAs, nurse practitioners, etc. So just clarified that. So once again, I thank Chair Wozniak and the committee members for your time. Really excited for this updated rule set that condenses 6 current AFC rule sets into a single rule set. This language is clearer, more concise, while continuing to ensure resident safety and protection. With that, I guess we open up to questions.
Thank you. I have a few questions to just begin with. Do you subscribe to the off-wall standards from the UK? They're supposedly used, or what type of standards do you, or is it just Michigan?
Yeah, no to your first question, we don't, but we do coordinate with other states, and so I'm part of NARA, which is the National Association of Regulatory Administrators, and so I just went to that conference last week actually, so we get feedback from other states and what they're doing and what's working, and so that went into part of this.
Okay, and with regard to say some of the residents may get a little too excited or anything, what type of rules are in place for restraint for those patients or residents? And is that just temporary, or if there's more than one incident, how do you handle that?
So that's going to be defined in their care plan on what can and can't be done. So they can't have chemical restraints. You can't over-medicate somebody, obviously. And then it should be the least restrictive as possible. So a lot of times it's trying redirection first, using blocking pads. So they'll have big blocking pads, basically, almost like when you see football players practice, right, to try to keep residents from hurting themselves or others. So the goal is not to physically hold somebody either, unless that is the only measure left.
With regard to the doorways and egress, can you put a time delay? I see what they term as a positive latching, non-locking door.
Yep.
So can you put a time delay on that to prevent elopement?
So that's a tricky question. That's so it depends on, I guess, the circumstances. Is that a door for that is part of the egress? And so if it's part of the egress, it's going to depend on those individuals in that home, because there's other factors besides licensing that oversee a lot of these homes, be it the CMH recipient rights or the home and community-based services that is payment. So they say, no, I guess you can't have that. There's also, depending on, so there's certain circumstances that they can be used, and there's certain circumstances that they can't.
Yeah. Does your department have a stance on that at all?
That's probably
Yeah, we follow currently we follow what is laid out for each individual patient. So what recipient rights has told us we have to do in consultation with the Bureau of Fire Services to make sure everyone can actually get out of the building if there is a fire. But that is how we handle it. But we rely on others, in their expertise, since ours is just licensing and then ensuring the individuals are safe inside the building that way. But we don't have a specific stance on door locking. We leave that to others, and then make sure we follow and are in compliance with what they need.
So you wouldn't object to door locking if it was called for?
I mean, we'd be happy to review any legislation that you are creating or working on and see.
Well, I know about once a year we see some person that's eloped, and then they're outside in the cold and they die. And if there maybe been a time delay, staff could have gotten to them while they're trying to elope.
Yep. And so that's where that home and community based, if they're a CMH client and home and community based payment is there, they would look at that as a restriction unless it was specifically identified in that individual's plan. And so that's where it gets real tricky. And sometimes I'm with you, I'm banging my head on on the table, like how do we protect these residents but also protect their rights? Because they're saying that the alarm is too noisy, or it's restricting their movement, and that all of us, we're in a battle with rights on those instances.
Which brings me to incident reporting. What do you require as far as death, hospitalizations, elopements, serious injuries? Is there a requirement by the department to report that?
So that, the way the rule is written, that report has to go to the resident representative and then a responsible party, which is usually the CMHs. And then they have to keep that on file in case we have an investigation for us to review, like if we get a complaint. Or we can review that as part of our renewal inspections.
A little differently, what is the relationship with Medicare and Medicaid? How do you handle those patients, residents, I'm sorry?
Yeah. Can you expand that a little bit?
Yeah, just how, do you get a lot of involvement with Medicare, Medicaid?
Yeah. Yeah. So, I mean, there are some residents that are SSI or SSD, and then Medicaid too. That's going to be some of your home and community-based waiver. That's all handled through the Department of Health and Human Services, but they are residents in our AFC homes.
So an AFC would be considered a waiver?
Yeah, that's one payment method, yes.
Great, great. Anybody else? Yes? What we got? Reports.
Thank you, Chair. And I just want to commend you all for taking this and turning it to this. This should be the standard that all departments should be working towards. So I very much appreciate that. And this is well done on that part. A few questions I have. One is, I know there was talk, and this comes kind of from personal experience in my own family. I had an aunt who cared for my grandmother until her death last summer at 93 with Alzheimer's in her home. And she fell in the spring of 24, broke her hip, and then it was just about ready to become weight bearing, and then woke up from a nap, has Alzheimer's, tries to get up, falls, breaks her femur bone, and then it was a decline from there. Alzheimer's, to her, my aunt had become her mother, her caretaker, everything. It was her companion. And what we were heard over and over is just send her to a home, just send her to a home, to which my aunt said no. I'm not doing that. My aunt also runs a daycare. So she brought her home to live out her days at home. But the frustrating part was the amount of in-home care. If she would have been in a facility, she would have, had care. I think she got 2 visits a week since she came home. And there's been some talk about how do we make it so family members can get maybe licensed or paid for some of that in-home care to avoid situations where people have to go to a facility. The only part I noticed in here was the last section where it says a family home smaller than 6 people, and that looks like it's just regarding fire safety. Is there any possibility or work on that?
So that's actually not in Laura's authority. That all of the payment is the department, is DHHS. So that isn't our part. Was I taking something?
Yeah, no.
It's the same. So we only are responsible for the licensing piece of it.
I guess, could a family then, if they wanted to get licensed, to get some qualifying for maybe care in home, is that an option under this with a unit of 6 or less?
Yeah, so it's 3 to 6.
3 to 6.
And so you'd have to have capacity for at least 3 individuals. You wouldn't have to take 3, but you'd have to have capacity to 3 to be licensed. And then it's, figuring out how to get that payment. So that's,
It's just like these stories, and I have another family situation where it's on my husband's side, but has a cousin who's now paralyzed, a former veteran. She gets 20 hours a week of in-home care. Again, they said, if you just go to a facility, you'd have round-the-clock care. She has 4 kids still in her home. She's not going to go to a facility. So how do we fill in that gap, I guess, or is there any way around that?
Adult foster care would probably not be the best solution for that, just given that the way it's designed, these individuals, there's no full-time nurse on staff. The adult foster care system is, as Jay kind of went over in the beginning, is not designed for individuals who need, more specialized care in that way. So it would have to be a different type of facility. So these rules wouldn't be able to encompass those particular individuals.
Okay.
We're sorry to
The
hear
other-
about your aunt.
Yeah, thank you. The other question I had is, what about if a person wants to leave and go spend time with family? Is there any rules in here about the ability to leave and come back, or are these considered almost only they have to stay unless they're discharged?
no, they can leave with family members. That happens, like a weekend visit or whatever that
Okay, and
happens
there's-
quite frequently. And then the facility is responsible, obviously, for providing medication if they're on medications and that type of thing
Okay.
to go home with that resident.
So then probably the follow-up question I have would also be related to Medicaid and Medicare, because there's some things stipulated in there about limited times, and I didn't see that in here, so that's not in your rule set? No,
not in our
okay.
rules.
Okay. And then my last question was inspections. I didn't see anything. How often are these inspected? Is that in here somewhere that I missed?
It's not in the rules, it's in our act, and it's
Okay.
on every other year is our renewal inspection. And then obviously if we get a complaint, we have to go out and investigate.
And there's 55.
Yeah.
And I was just going to say, there's 55 inspectors.
Okay. And how many statewide facilities?
3,900. So they have a caseload about 72-ish. And then they usually do about 60 to 70 complaints a year.
Okay. So it's biannual inspections. Okay. There was one other thing I wanted to compliment you on. I think this should, though, be like bold and at the beginning, is that it's on page 24. A resident shall be treated with dignity and respect, free from exploitation, and protected and safe. Like,
That is our catch-all rule that
I've been in
say quite often.
varying facilities over the years, oftentimes to Christmas Carol or go visit, and there's places where this is done very well and places where it's done very poorly. So I think that should be the standard by all. So thank you, and I'm glad you put that in there.
Thank you, Rep. Wertz. Rep. Johnson.
Thank you, Mr. Chair. I agree. Excellent job. This is nicely done. 2 questions. First one, what is the process for oversight? I have helped 2 constituents report on 2 facilities, one specifically adult foster care, and like while the ink was still drying, the case was closed. I don't understand. I don't know what I didn't do to help them get proper process. Adult gentleman got beaten pretty badly by one of the employees at Old Town AFC in Kent County, and nothing done.
Yeah, I don't know that one specifically, but we can
Right.
look into that and get back to you. Obviously, if we get a complaint, we're going to assess, did we investigate it already? And so sometimes we might, I'd like to see if we got the complaint or if that complaint went to Adult Protective Services.
I think it went to APS.
And so they might close their the complaint on their end, but they refer that to us. And so even though it, like you said, it was closed immediately, that makes me think that it went to Adult Protective Services first. If that resident is no longer there, they don't have oversight, so they'll send it to us.
Guardian pulled them out,
Yeah.
but there was nothing.
Yep, and so we'll investigate. They also report that, in this case, since it was physical abuse, they'll report that to the police to investigate for a criminal matter. But
Okay.
we'll, when we get that
Do you
complaint,
automatically get a notification, or not necessarily? Does it have to be refiled through Laura, a different process?
it doesn't. It's always a good idea to file it with us, but APS has if they connect that it's at a licensed AFC, they will forward that to us.
Okay, we'll look into it more. out of this.
I can email your office after this to, get the address and everything so we can do
That would be great.
a thorough,
Thank you.
review and shoot it to you. But I'll make a note to shoot you over that piece. But yes, it's not, to summarize your question, no, Laura doesn't get it automatically unless someone files a complaint directly with Laura.
If you go directly to the police, does it go to Laura? No. Okay, that helps me know better process it. The other question is, in your opinion, would you like state institutions to come back?
You guys are the lawmakers, and we're willing to review any legislation you have or any piece that you are interested in pursuing. At the moment, we, follow what is laid out for us from previous lawmakers, which is institutions are the direction we're moving away from. So we only have 4 that are grandfathered in.
But you have no strong opinion
We're
either
happy
way.
to review it. That's something, if you want to dive deeper into, we would take back to the council that Jay mentioned. We have experts that are part of a panel. I believe 11 total are on that, and we would, look to the experts to discuss that with, opposed to just giving, a full flat out opinion on it. But that's how the rules were, revised, and that's why we have a council to begin with to help work through some of those issues. And they're great. So, as Jay thanked them, we really appreciate all the work that they do above and beyond their regular jobs every day.
Thank you, Rep. Senator Tice.
Thank you, Chairman. Thank you for this. It's so awesome to see these things shrink. It's just very unusual. We're really grateful. With respect to the institutionalization, I understand absolutely the direction we were trying to go, pulling away from it. But are you aware of any analysis that shows the cost impact of those decisions that have been made? We hear all the time about how expensive this kind of care is, and how impossible it is for people as they're getting older to be able to afford wherever they're going, right? And it seems like we've regulated out some of the less costly options, and it's always going to be a balance for what the best way to do it is. Are you, to get back to my question, are you aware of any financial analysis to show the cost impact of the regulatory changes that we've made?
We can double check with DHHS, but again, we're just the licensing part, so we don't have a role in the cost part of it. That does come from DHHS.
I wanted to circle back on one of the questions I have with regard to the elopement and egress. If I'm understanding correctly, your department doesn't have any position on that, but the federal rules prohibit time delay. Is that correct?
Just some of the recipient rights do, yeah. So not necessarily, well, I guess it is federal rules because that's where the funding's coming from, yeah. So
But
recipient rights and
The federal rules prohibit time delay?
Any restriction from freedom of movement. So it might be the time delay, it might be like an alarm on a bed, it might be a buzzer on a window. All that stuff has to be specified in that resident's care plan. And if it is, then sometimes they can use it, but then you have to also think of the other 5 individuals, in a 6-bed home. Do they also need that same restriction? So that's where it gets real tricky, right? Like almost everybody has to have that restriction where they're elopement risk in order to put that, like you're talking the 15-second push button or push bar on a door.
But your department has no position on it.
Not necessarily my area, but Bureau of Fire Services also follows NFPA, and that has some specific guidance on when a delayed egress, like a push bar, can be used or not used.
Okay. So it's a murky area.
Yes. If then.
Okay. Any more questions? No? Okay. Well, thank you for your testimony. It's very enlightening, and I think this has been overdue, but it's like almost a breath of fresh air after the other departments we see trying maybe to complicate things. It's a good simplification. So thank you for that. We have a couple cards to read in. Wishing not to speak is Rich Farron. He does support the bill. And wishing not to speak is Bob Stein, but he does support the bill from the Michigan Assisted Living Association. And I should have said Rich is from the Healthcare Association of Michigan. But if we have any unread cards, they'll be included in the minutes of today's meeting. Rep. Johnson moves to excuse absent members. There being no objections, the motion prevails by unanimous consent. There being no further business, this meeting is adjourned.